Greetings. Thank you for joining me today. Today, we will be talking about taking control of pain, exploring options for using opioids wisely. We will talk about what matters most: function, safe medication use, and quality of life. My name is Dr. Donna Lisi. I'm a clinical pharmacist. I hold board certifications in pharmacotherapy, geriatric pharmacy, psychiatric pharmacy, ambulatory care pharmacy, and medication therapy management. I'm also a fellow of the American Society of Consultant Pharmacists and the American Association of Psychiatric Pharmacists. I also am a certified professional of age-friendly healthcare, as well as a certified dementia practitioner. It is my pleasure to be with you today to discuss this important topic. I do have a disclosure. Certain images were generated by AI, but I have reviewed and edited and verified all content for its accuracy, appropriateness, and context before I incorporate it into this webinar. This material is intended for educational purposes only and does not constitute medical advice. Individuals should consult their healthcare provider for personalized medical guidance. I found this poem and I thought it would be a great way to start off this discussion. This poem was written by Jamie Fleischman when he was a second-year doctor of physical therapy student. It reads, "Give me sympathy and I will bear down, dig in, clam up. Give me sympathy and I will avoid and erase my pain for you. But give me empathy and I will share my burden. Give me empathy and my humanity is unlocked. Give me empathy and I am open to healing." I found it very insightful, and it's at the core of what we will be discussing today, that you are not alone on your pain journey and that you are empowered to be a self-advocate and an active partner in your pain management. Since this presentation is focused on using opioids wisely, I thought it would be best to define what an opioid is. Opioids belong to a class of medications called analgesics, or pain relievers. They work by binding to receptors, which I'd like to think of as docking stations, in the brain and nervous system. Once the opioid binds to the opioid receptor, it produces a response. The response that we want is relief of pain. But unfortunately, other effects also occur, such as respiratory depression and constipation, to name a few. I do want to preface this discussion by saying that while pain is more common in older adults, it's not a normal part of aging. That being said, here we see that the use of medications, in particular opioids, is quite common. About 13% of adults living in the community aged 65 and older used at least one opioid prescription, and about 4% had 4 or more opioid prescriptions in the same year, 2020 to 2021. About 5% of Medicare beneficiaries became new opioid users in 2020. And among the new users of opioids, about 11% transitioned from short-term use to long-term use of these medications. Here we see common reasons why older adults use opioids: for back pain, osteoarthritis or joint pain, and for other musculoskeletal pain. While opioids have been commonly used for these conditions, non-pharmacologic or non-medication approaches, such as physical therapy, are often preferred and can be highly effective for improving pain and function, with fewer risks than with medications. We also see that the most common opioids were short-acting opioids as opposed to long-acting agents, and that patients with cancer were more likely to be prescribed these medications than those without cancer. And that makes sense because these are potent, powerful pain medications which are often needed to treat cancer pain. I'm sure that many of you may recognize this iconic performer. This is Tom Petty. Tragically, he passed away from an accidental medication overdose. Opioids prescribed for pain. Following his passing, his family went on to issue these statements that Tom suffered from many serious ailments, including emphysema. Emphysema or any lung disease makes one more susceptible to respiratory depression from opioids. He also had knee problems and, most significantly, had been diagnosed with a hip fracture on the day that he died. His family felt that the pain from the hip fracture likely caused his overdose. I find this quote in the Blue Shape particularly touching. Even though his family was experiencing tremendous grief, they used their pain to alert others and to show that you are not alone in your pain journey. They said that as a family, we recognize this report may spark a further discussion on the opioid crisis, and we feel that it is healthy and necessary discussion, and we hope in some way that this report can save lives. Many people who overdose begin with a legitimate injury or simply do not understand the potency and deadly nature of these medications. That is why we're here today, to help you understand about the proper use of opioids. Tom Petty died October 2nd, 2017, at the age of 66, shortly after he finished his 40th anniversary tour with his band, Tom Petty and the Heartbreakers. There is a movement called the age-friendly movement that is reshaping the way that we give care to older adults. The patient is at the center of this model. It focuses on 4 areas called the 4 M's, which stand for what matters most, medications, mentation, and mobility. The focus is that everything else revolves around what matters most, and that the medications, mentation, and mobility do not negatively impact what matters most. The 4M model assures that care is aligned with each older person's specific health outcome goals and care preferences across the care spectrum, meaning that whether you live in the community or in assisted living or are in a hospital or in a long-term care setting, care is focused around the patient's healthcare goals and preferences. We've talked about what matters most, so let's explore the other 3 M's. Medications should be chosen that do not interfere with what matters most to the older adult, to their mobility, such as avoiding medications that can cause dizziness or confusions, or to their mental functioning. The model of care also focuses on preventing, identifying, and treating or managing mental health conditions such as dementia, depression, or delirium, and helping to make sure that medications aren't playing a role in causing these problems with mentation. With mobility, the model helps ensure that older adults can move safely every day in order to maintain function and to be able to do the things that matter most to them. To make sure that they maintain their functional ability, that is the goal of pain management, not the total relief of pain, as it may not be possible to safely achieve that end, to have pain totally eliminated. This is a high-level overview of common types of pain. The first pain is acute pain. This is pain with a sudden onset. A good example is dental pain. Next is episodic pain. This comes and goes, like, for example, a migraine headache. Chronic pain is pain that lasts for 3 months or more. This is where osteoarthritis or joint pain fits in. Nociceptive pain is pain that's caused by tissue destruction, inflammation, or both. Here, a good example would be surgical pain after a procedure. Neuropathic pain is caused by nerve damage. This can be due, for example, to diabetes, or it can be the results of having had shingles. Nocioplastic pain is pain caused by changes in how the nervous system processes pain. An example here is in fibromyalgia. It is important to recognize that uncontrolled pain can affect so many aspects of our lives. I have 5 areas listed here: sleep, mobility, mood, social engagement, and independence. Sleep is critical for maintaining cognitive function, emotional stability, and repairing the body. If pain interferes with sleep, we can become irritable, feel stressed, have poor concentration, and even increase our risk of heart disease, depression, and obesity. For mobility, regular physical exercise helps to maintain physical function and prevent decline. If there is pain, we don't want to engage in physical activity. This can lead to loss of functional status and loss of independence. We've already mentioned mood. A combination of good sleep and exercise is effective in managing mood disorders. And with pain, we may not be able to do either and get any of those benefits. Social engagement is essential for good mental health, for reducing isolation, which has become a national epidemic, and for enhancing our overall life satisfaction. Social engagement also helps prevent cognitive decline, as does adequate sleep and a healthy lifestyle. Lastly, maintaining independence involves a combination of all of these: mobility, a positive attitude, and a consistent sleep pattern. This helps to prevent functional decline. This is especially important if we're to be able to perform the activities that matter most to us. As you can see here, uncontrolled pain can negatively impact all of these areas. And these are the areas that matter most to most older adults. I want to shift gears a bit and address factors that can contribute to opiate use and misuse in older adults. We've touched on some of these already. Older adults have multi-comorbidities, which means that older adults have multiple medical conditions that can impact and cause pain. They undergo more surgical procedures, for example, and they're on more medications. These medications, benzodiazepines, gabapentin, or sedating antihistamines, which are often prescribed in older adults, can increase the risk of respiratory depression when used with an opioid. There are changes in the way the body handles medications as we age. We have changes in what we call pharmacokinetics and pharmacodynamics, what the body does to a drug and what the drug does to a body. Problems with memory can lead to taking more opioids by accident, which can lead to falls in addition to respiratory depression. And as we mentioned before, underlying respiratory diseases increase the risk of respiratory depression. Additional factors include a past history of substance use, which may lead to a greater chance of opiate misuse. Also, using opioids to treat existential pain, which may be caused by regrets in life, or to treat depression or anxiety, or to deal with isolation or loneliness, can lead to overdose. There can be unsafe medication practices, such as sharing medications among family members and friends. While good intentioned, it is a dangerous practice and should be discouraged. There can be inappropriate prescribing of opioids, for example, for mild pain. There can be a failure to use less potent medications first, like acetaminophen or Tylenol, which is indicated for mild pain, or to use less potent medications that, when they're used, they don't relieve pain, causing the need to go to higher or more potent medications, or the failure of more potent medications. All of these can be factors that can lead to opiate misuse. Lastly, shopping for medications by going online or different doctors or different pharmacies can also lead to problems. One of the problems is that there's a lot of illegal pharmacies or illegitimate pharmacies online that can be selling patients dangerous medications, which can lead to an overdose. The title of this webinar is Taking Control of Pain and Exploring Other Pain Medication Options. Here is a great place to start with non-drug or non-pharmacological options. I group them into three categories: restorative therapies, such as physical therapy, and as which helps to restore function and decrease pain and increase mobility. Behavioral health approaches help a person with pain cope with the pain, especially if the cause is known and is not life-threatening. This can include various strategies such as mindfulness or cognitive behavioral therapy, which can also help with depression and sleep. The last group is complementary and integrative health. There's non-drug strategies here. These strategies can improve the mind and body, such as spirituality or engaging in Tai Chi. The American Geriatric Society has come out with pain management guidelines. Here we see the treatment approaches for pain management in older adults. This is how they recommend treating pain, starting from mild to severe, starting out first with non pharmacological interventions that we just mentioned. It's helpful to continue these non pharmacological interventions if they're providing some benefit, even as we start adding medications to the regimen. So, if we need pain medications, what other options are there besides opioids? There are many. However, just as with everything in life, we have to weigh risk versus benefit. I have a list here of different classes of medications or different medications that are used or have been tried for pain. Among them are acetaminophen, better known as Tylenol, nonsteroidal anti-inflammatory agents, mood stabilizers, which were originally marketed for seizures and then marketed for bipolar disorder, antidepressants, topical analgesics, which are preferred in older adults because they have limited side effects, and then more invasive measures such as local or regional nerve blocks. Ketamine has been tried, skeletal muscle relaxants, which are not recommended to older adults, and finally, cannabis has been used too, and we'll say a few words about that in a minute. Here I have drug classes used for pain and listed medications that fall into each class. There are guidelines called the Beers criteria for the use of potentially inappropriate medications, or PIMS. PIMS standing for potentially inappropriate medications in older adults. These criteria were originally released in 1991. When they first came out, they were only applied to nursing home residents. But by 1997, they were widely embraced and were applied to all older adults, even those who resided outside a nursing home. They became updated every year since then, and the last version of it has been in 2023. Here I show you classes of pain medications addressed in the Beers criteria that are considered PIMS, or potentially inappropriate medications in older adults. This does not mean that they should never or could never be used. This does mean that there are generally safer alternatives, and discuss these alternative options with your doctor if you're given one of these medications. We just mentioned skeletal muscle relaxants should be avoided. These medications can lead to confusion and falls in older adults, and they aren't very effective. Nonsteroidal anti-inflammatory agents such as Advil or Nuprin, or prescription drugs like meloxicam, should be used in the lowest dose and shortest duration possible because they can have adverse effects on the kidney or on blood pressure, and they can lead to gastrointestinal bleeding. For acetaminophen or Tylenol, doses should not exceed 3 grams a day, or 3,000 milligrams. And that's from all sources. Meaning, if you're taking a cough and cold medication that contains acetaminophen, or a prescription medication like Percocet that contains acetaminophen, between all of those, they should not exceed 3,000 milligrams, or 3 grams of acetaminophen a day. On the next slide, I have some examples of medications that contain acetaminophen. Excessive doses of acetaminophen can severely damage the liver. If this is compounded by the use of alcohol, it can be that much more severe. If you take acetaminophen, do not use alcohol. We talked about nonsteroidal anti-inflammatory agents, especially with chronic use. These can even interact with diuretics or water pills, which are meant to lower blood pressure, and these can antagonize the effects of the water pill or the diuretic. The same thing, too, in heart failure. If water pills are used to try to release water from the body, this can antagonize the effect, and we can have fluid retention. Drugs like gabapentin or pregabalin, Neurontin or Lyrica, can lead to sedation and falls, and they need lower doses in patients who have reduced kidney function. Venlafaxine is an antidepressant. Duloxetine or Cymbalta fall in the same class of medications as antidepressants as venlafaxine. Venlafaxine can increase the blood pressure, and both venlafaxine and duloxetine or Cymbalta have drug-drug interactions. Your best choice for localized pain is a topical nonsteroidal product, something like Voltaren gel. This produces little side effects in other parts of the body and avoids the potential for drug interactions. The key is to be familiar with high risk medications and consider the use of safer medications, and to be aware of the side effects if they are being used so that you can identify any risks you have and discuss this with your doctor. Here are some products that contain acetaminophen. Even medications that provide relief for, say, mucus or for sleep can contain acetaminophen. And again, the total amount from all these products should be no more than 3 grams or 3,000 milligrams a day, because excessive exposure to acetaminophen can cause liver damage. Here we have the next step if pain progresses to more moderate or severe pain. Step 1 is using non-opioids that we just talked about, acetaminophen or short-term use of nonsteroidal anti-inflammatory agents, but most preferably topical nonsteroidal anti-inflammatory agents. Mild pain is a score of 1 to 3 on a pain scale, and it is associated with limited functional impairment. You can still do the things that you need to do and what matters most. In more moderate pain, now we have pain score of 4 to 7, and there is interference with function. Still, we may be able to do things, but we might have a degree of pain as we're trying to function. Here we may consider opioids, short-acting ones. We can consider antidepressants or mood stabilizers, which are also anticonvulsants that we just talked about. If pain is localized, botulinum toxin can be used too, as well as corticosteroids for bone pain. These might help as well. I have listed here cannabis and cannabis-related products. The evidence is very limited, and cannabis has only been shown to have modest benefit in very specific types of pain. For example, pain associated with multiple sclerosis. In severe pain, which is when you have a pain score of 8 to 10 on a pain scale, this has more marked negative effects on function, and pain now is affecting quality of life. Here, opioids can be considered, but caution must be taken to prevent falls, and they should not be used with benzodiazepines such as Ativan, Valium, or Xanax. This slide shows more intensive strategies for moderately to severe pains. These can be more invasive, such as implantable devices, as well as surgery. We just discussed the Beers criteria. Here we see pain management alternatives to the drugs that have been considered potentially inappropriate in older adults, or PIMS. Right under the title is a URL of a podcast that I did on the Beers criteria. And the links in the bottom of this page include a link to alternatives to the Beers criteria, as well as the whole Beers criteria. The box to the right includes alternatives to the Beers criteria specifically for pain. This is a protocol that may be used in emergency rooms and emergency departments throughout the country. It's called ALTO, which stands for Alternatives to Opioids. The medications in red are PIMS, or those potentially inappropriate medications that are on the Beers list. I would advise caution if they are used in older adults, as older adults might experience adverse effects from these medications. As with all medications, and really all things in life, we need to weigh risks versus benefits. So too with opioids. Here we see the risks include sedation and cognitive impairment, falls and fracture, and respiratory depression, which we've talked about a lot. We've also mentioned opioids can cause constipation. They're subject to drug interactions. Patients can become dependent and misuse opioids and develop an addiction. There can be an accidental overdose, or an overdose can occur from repeated doses, what they call cumulative toxicity, if the body is not excreting or eliminating the medication. They can also reduce functional impairment, which sounds paradoxical because there is a situation in which the more opioids someone takes, the worse their pain can get. We've talked about altered pharmacokinetics. If someone has impairment in their kidney function, the drug might hang around a lot longer in the body. And also, too, with certain medications, for example, like methadone, There can be changes in the EKG, which can cause arrhythmias. Here I have listed QT prolongation, and this can lead to arrhythmia called torsade de pointes. But there, just like with everything in life, there also are benefits. These are very effective for moderate to severe pain. For patients who have moderate to severe pain, they can improve function and improve sleep, and they can enhance the quality of life. I think about the typical patient who just underwent a knee or hip replacement. This facilitates participation in therapy, and opioids are commonly given right before someone needs to go to physical therapy. They're useful for palliative care, comfort care, and cancer related pain, and also short term use of acute pain, such as following surgery. The important thing is that care must be patient centered, considering what matters most to the older adult. So, why are we focusing on risks so much? Well, we all have heard about the opiate epidemic. It has come in four waves. The first wave was from 1998 to 2010 and was due to the risk of prescription opioid overdose deaths. This was in part due to the misguided notion that all pain needed to be eliminated. The cost was not taken into consideration. Misleading information from pharma like Purdue Frederick, the maker of OxyContin, downplayed the risk of addiction and abuse potential from these drugs, and they did this for profit. Next, from 2010 to 2014, we saw a rise in heroin. This happened as we clamped down on prescription opioid prescriptions and put limits and safeguards for excessive use in place. The third wave was from 2014 to 2019 and involved heroin being replaced by synthetic fentanyl. It was made in a lab. It produced a more consistent supply since the illicit producers did not have to depend upon growing conditions for heroin, which came from the poppy plant. In 2019, we see that heroin is pretty much replaced by illicit fentanyl, and now we see that it's starting to be combined with psychostimulants, drugs like cocaine and methamphetamine. Both taken separately can be deadly in an older adult. This shows you that older adults are not immune to the opiate crisis. Here we see age-adjusted drug overdose deaths among those aged 65 plus from the year 2000 to 2020. And we could see on the far right that men exceed women in deaths, but both men and women, the curve has risen up higher from 2000 to 2020. To drive home the point further, from 2022 to 2023, older adults, that means age 65 plus, had the highest percentage increase in the rate of overdose deaths compared to other age groups. I serve on my county's overdose fatality review committee, and we are seeing this, older adults dying from fentanyl in combination with either cocaine or methamphetamine. The issue is getting recognition. Here we see a report from the U.S. Senate Special Committee on Aging. AARP has called out the alarming increase in opiate overdose deaths among older adults, and the Washington Post draws attention to the fact that the problem is largely unseen, but is growing among older adults. So what should you do if you receive an opiate prescription for pain? If it is necessary, take as directed. Check with your doctor as to whether you need to take it if your pain improves, when you can stop. Watch out for side effects. Hopefully, we have empowered you to recognize those adverse effects associated with the medication. Store the medications securely. Keep them out of range of children or pets. Do not take with alcohol with other sedatives. Dispose of them properly, and we'll talk about that more a bit. And check to see how long you need to be on the medication. Maybe the doctor wants to make sure that you can do exercises at physical therapy, so he doesn't want you to stop it too soon. Or maybe the doctor feels that your pain should be better by now and that it's time to stop it. Have that conversation. Additional pointers. These medications are indicated for severe pain. If your pain is not severe, talk to the doctor. Maybe using a less potent medication might be helpful. Talk about side effects and drug interactions that can happen when you're on an opioid, especially if they're combined with other medications. As we mentioned, do not share medications. Properly dispose of them, as we said, and then also have a supply of naloxone readily available on hand and to tell family and friends. This is a major point that I really want to stretch because naloxone can save lives. It's available without a prescription, and a lot of nonprofits, like your county office on aging, may be able to tell you how to get naloxone for free. If you are prescribed a long acting medication such as Oxycontin, do not crush or chew the pill, as this will release all the medication at once, potentially leading to an overdose, since the drug is supposed to be released slowly during the day. If signs of respiratory depression are present in a loved one or even a stranger for that fact, and you have naloxone on hand, I would really strongly recommend using it because it has limited side effects, but it can save a life. Let your doctor and pharmacist also know everything that you're taking because there can be interactions, for example, with dietary supplements. Accidents happen, so be prepared. This was a study from the University of Michigan. It looked at what healthcare providers talk to older adults about when they prescribed opioids. Less than half of the time, they talk to older adults about the risk of addiction, the risk of overdose, and what to do with leftover pills. Here are some tips when talking to your doctor. Discuss all of your conditions, especially if you go to multiple specialists or use different health systems. Share your pain level on a pain scale. I will explain that in more detail in the next slide. Review past medication history. Are there medications that you no longer need that can impact or interact with opioids and that they can be discontinued or deprescribed? Tell your provider if you've fallen recently or if you have breathing problems. Ask about side effects, especially ones that you may be more prone to because you have underlying conditions like emphysema. And importantly, discuss goals and have realistic expectations of how much your pain can safely be relieved. This slide shows you examples of pain assessment tools. They help you rate your pain so that your doctor knows if your pain medication is working. Verbal descriptor scale uses descriptor words to identify the level of pain. The FACES pain scale goes from a smiley face for no pain to an agonizing face for worse pain. The numeric rating scale rates pain on a scale of 1 to 10, with 10 being worst pain possible. A pain diary is very helpful as you're able to record what triggers your worst pain, what makes it better, and the time of day that the pain is worse. All these different factors that can help the doctor determine what's the best course of action for you for your pain management. Pain AD is a scale that's specifically designed for people with dementia who may be unable to communicate the presence of pain. Here, the scale looks at physical characteristics such as body language that may indicate the presence of pain. Lastly, a pain thermometer like the one here, it's like a numeric rating scale. The higher the number, the worse the pain. We've talked about not mixing opioids with alcohol, and we may know about not mixing them with gabapentin and pregabalin and sedating antihistamines, since we just talked about that. But what about cannabis? More and more data is showing that this substance poses a real risk in older adults. A study from Canada, where Canada had legalized cannabis in most of the provinces, found that cannabis poisoning increased, as did emergency department visits in those regions that had legalized recreational marijuana. We don't even have to look that far. In California, a study found that cannabis-related emergency department visits increased significantly following legalization of recreational marijuana. A subsequent study found that followed those who went to the emergency department for a cannabis-related adverse effect that were age 65 and older, that 5 years later, those patients who had a cannabis-related emergency department visit were significantly more likely to develop dementia. Also, since older adults are on many medications, it's important to realize that there are about 400 known drug interactions with cannabis, and over 2 dozen are considered major, meaning that they can cause significant harm. Penn State College of Medicine developed a drug interactions checker for cannabis called CANDIRE, which stands for Cannabis Drug Interaction Review. It's free and it's web based. There is some other information showing the risk of cannabis in older adults. On the left side is a case of an older woman who had a cannabis laden brownie. Soon after eating that, she collapsed and died. The cause of death was cannabis intoxication and severe cardiovascular disease. Cannabis is thought to have made her ischemic cardiovascular disease worse. On the right hand side is a scientific statement from the American Heart Association, where they talk about medical marijuana, recreational cannabis, and cardiovascular health. And they warn about the risk of heart attacks, arrhythmias, which are abnormal heart rhythms, stroke, and sudden death from cannabis. On the other hand, there is limited but questionable data as to whether it may have an anti-clotting effect. Here is a list of dietary supplements and other substances that can also interact with opioids. Cannabis is on this list. I mentioned that we would discuss safe storage of opioids. You can purchase locked cabinets or safes or even locked medication bags. These are helpful if you have a lot of people coming and going outside your house, or if you have teenage grandchildren or a family member with a history of substance use. Keep these medications out of the reach of children and dispose of any leftover medication safely. This is also from the University of Michigan, that survey we just talked about. This question looked at what older adults did with leftover opioid medication. 1 in 9 threw them in the trash, and the overwhelming majority, 86%, saved them for another time. Twice a year, in October and in April, the DEA holds what they call a Prescription Drug Take-Back Day. They also accept over-the-counter medications and dietary supplements, so it's not just for prescription medications. This usually takes place at a police department. In March 2025, manufacturers of opioids have supplied pharmacies with prepaid drug mailback envelopes that can be made available to pharmacies. And then these can be passed along to patients to return any of their unused medications to the manufacturer for destruction. There are other options for safe medication disposal too if you miss the DEA take-back day or they're not holding one in your area. These pouches, what we see Dispose RX and Deterra, inactivate medications so that they can safely be put into trash. There are also community drop boxes that you can dispose of old medications. Typically, these are at pharmacies. If you go to this website, this DEA.gov website, it will help you locate collection sites in your area where you can safely dispose of old medications. Typically, it will be a police station or a pharmacy. So why all this fuss about not putting medications in the trash? Well, children or pets can accidentally get into the trash. If there are opioids in the trash, they can be diverted and sold on the street. Medications can end up in groundwater and can also cause local water pollution, or wildlife might get access to them and it can kill them. Once I saw a raccoon going through the trash at my local Dunkin' Donuts. We have been talking about being your own advocate and being empowered. I like this quote. Health is a state of complete harmony of the body, mind, and spirit. When one is free from physical disabilities and mental distractions, the gate of the soul opens. Mental health is health, just like physical health is health. And just as we can have a physical condition that affects our well-being, so too we can have a mental health condition like substance use disorder, which distorts this harmony of mind, body, and spirit. However, often due to ageism and stereotypes, substance use problems in older adults go unnoticed. We hear things like addiction screening don't happen for seniors. The assumption is made that because they're older adults, they won't be abusing medications, but the rates are increasing. Another assumption is people don't expect older adults to misuse or abuse opioids. They tend to think the symptoms of overuse are related to aging rather than drug use itself. And lastly, doctors may approach the situation thinking that the older person is going to die anyway, so why bother treating the opiate use disorder? This is not normal. This is ageism, and it's contributing to the spike in drug overdose deaths in older adults. As health professionals, there are red and yellow flags that we look at to try to alert us if someone needs help. Running out of pills early, frequently losing a prescription, getting prescriptions from an opioid from different doctors. One of the major telltale signs is an accidental overdose. Other signs include taking more medication than prescribed and running out of medications earlier, being isolated or withdrawn, which may also be from the pain, going to the emergency department often to get opioid prescriptions, and having frequent falls or accidents or broken bones that cannot be explained by other reasons, such as, for example, falling from Parkinson's disease. I can't stress this enough. We need to have the talk. Naloxone or Narcan saves lives. We need to destigmatize this medication. A change in medication, a drug interaction, a change in kidney function, a drink with friends. An overdose can happen unintentionally, even if someone is using an opioid as directed, because other things have changed. Being knowledgeable of the signs and symptoms of an opioid overdose are so important. Looking for small constricted pupils, slow, shallow breathing, or no breathing at all, or gurgling sounds, someone's body being limp or having blue lips or blue fingertips. These are all signs of someone who's not breathing. Most opioid emergencies happen in the home, in front of loved ones. So be prepared. It is like an umbrella when there's a chance of rain. You may not want to use it, but it certainly is good to have if you need it. Naloxone is an antidote. Remember that those receptors that we talked about, those opiate receptors, those docking stations, naloxone removes the opioid from those receptors and restores the ability to breathe again. And that's what saves a life. When persons die, they die from respiratory depression. And so this drug helps reverse the respiratory depression associated with with an opioid overdose. And that's how it saves lives. It's such an important message to get out among older adults in the community that the Gerontological Society of America released a publication called Staying Safe with Opioids at Home. It can be found on the link provided in this slide. Here are some key points from this publication. The first, naloxone restores breathing in someone who has overdosed, and that naloxone is available without a prescription. Now, next, as we talked about, be prepared, especially if you or a loved one are on an opioid, or if you have a loved one with a substance use disorder. Naloxone only temporarily reverses the effects. Sometimes more than one spray is used or needed. Naloxone comes in a box of 2 nasal sprays. The medication should be stored safely, as we just mentioned. If someone is unconscious and you have naloxone, use it and then call 911. Sedation and opioid overdose may be hard to tell apart. When in doubt, act. As we said, if someone has been safely using opioids, accidents can still happen. Naloxone will not hurt if it turns out that the person has not overdosed on an opioid. More take-home points. Lay, spray, and stay. Naloxone comes as a nasal spray. I cannot stress this enough. Do not prime the spray. By that I mean do not shoot the spray in the air like you may do with a nasal spray, such as a steroid nasal spray or a decongestant nasal spray. Those nasal sprays, you're told to prime the pump. With naloxone, please do not do that. There is only the right amount of medication in the nasal spray. Priming it or shooting in the air will lose all of the medication and you'll have nothing to save a life. Number 10, give naloxone, then call 911. I just said that, but it's worth repeating. Number 11, every second counts. Number 12, sometimes, depending on the opioid, multiple doses of naloxone may be needed. The box contains 2 sprays, so if one doesn't work, there's a second one that would be administered in the other nostril. If naloxone is used, the patient should be evaluated by a healthcare provider. Once used, the naloxone supply should be replaced. This guide has a decision tree to help people act quickly. And then lastly, June 6th is National Naloxone Awareness Day. There are effective treatments for opiate use disorder. This slide includes them: buprenorphine, methadone, and naltrexone. As with all medications, each one has advantages and disadvantages, and this topic alone can easily be a 1-hour presentation. I have some take-home points on this slide for you. Medications for opiate use disorder are highly effective, but they are often underutilized in older adults. Another important topic that I'd like to touch on is that of fake pills. These are pills sold by illegal pharmacies online. As of October 2024, the DEA found fake online pharmacies that sold these pills to customers in all 50 states. These pills are often advertised for sale without a prescription, which is legally impossible because these are controlled substances. These pills often don't even contain what they say they contain. Instead, they contain illicit fentanyl. Amazon stopped selling pill presses because people were setting up clandestine labs and making these illegal pills in their home or in their garage. Can you tell which is the real oxycodone tablet, the right or the left side? Also, if you scan this QR code, it will take you to the DEA website. There they have a campaign called One Pill Can Kill. This is what can happen if you take a fake pill. So, did you get it right? The fake pills are made to look so realistic. The fake pill is the one on the right-hand side. It's literally impossible to tell them apart. In fact, the fake pill looks like it's in better condition than the real pill. If you scan this QR code on the slide, it will bring you to a website where you can check to see if an online pharmacy is legitimate. This is a campaign from the National Association of Boards of Pharmacy, and it's called Before You Buy, Verify. Verify that the pharmacy is a legitimate pharmacy, and do not use them if it's not. This is my final topic, and we will come full circle. This is a module that was developed by the VA. It's called Whole Health Model. The whole health model for patient care is all-encompassing. It is more than just treating a particular symptom or disease. It includes recognizing the patient as a whole person, not just a diagnosis, illness, injury, or disability. It involves examining the effects manifesting throughout the patient's body, mind, and spirit to enhance the person's life and total well-being, and placing the patient as an active partner at the center of all aspects of his or her health. Compiling a team to help the patient meet goals for overcoming health issues, as well as daily living and future goals. It also incorporates a range of conventional and complementary approaches like mindfulness education to promote self-care and healing, and alternative therapies like yoga, acupuncture, massage, meditation, and biofeedback, among others. And lastly, and emphasizes the importance of relationships and partnerships with a team of providers and community resources available. The whole health approach to pain management starts with what matters most to you, not just what is the matter with you. The goal of the whole health approach is to improve function, not eliminate all pain. This is not safe or feasible. It focuses on making sure the patient can do their daily activities and maintain their quality of life while achieving what matters most. And as we started out, it achieves this through multiple pathways: mindfulness and relaxation, exercise, movement and activity, proper nutrition, adequate sleep, and social connections. Medications are only one tool in the whole health approach to pain management. The patient is an active partner. There is shared decision making. Care is aligned to the patient's goals, values, and function. Better pain care equals better function, a better life, not just less pain. This is a checklist called My Health Checklist that is available online. You can print this out and share it with your healthcare team. This can be used to address your pain concerns. It focuses on the 4 M's that we've mentioned earlier, always keeping what matters most central to everything that's done. Here are some resources that are available free online. And with that, I want to thank you for your attention. I hope that you found this program educational, informative, and empowering. Thank you, and be well.